Namaskar world, and welcome to our channel. Today we're going to talk about a tropical disease that you may not have heard much about, Oropouche fever. It's not as well known as dengue or malaria, but it's becoming an important public health concern in many parts of the world. Let's dive into what Oropouche fever is, how it spreads, and how it affects those infected, including special considerations for pregnant women. Oropouche fever is a viral infection caused by the Oropouche virus, also known as Orovie. It's transmitted to humans through bites from infected midges, particularly the Culicoides pariensis species, with mosquitoes such as Culex quinquefasciatus also possibly contributing. This viral illness typically affects people in tropical regions, especially in Central and South America. The Oropouche virus was first isolated in 1955 by the Oropouche River in Trinidad and Tobago, but the first major human outbreak was reported in Brazil in 1960. Since then, over 500,000 cases have been reported, primarily in the Amazon region and other tropical areas. Oropouche has been recognized as among the most neglected of tropical diseases and as an emerging infectious disease. Little is known about its epidemiology, pathogenesis, and natural history, and there is no specific treatment or vaccine. The Oropouche virus belongs to the Perubunia viridae family. It is carried by insects, primarily midges, but has also been found in some species of mosquitoes like Culex quinquefasciatus. When these insects bite humans, they transfer the virus into the bloodstream. Oropouche fever is endemic to tropical regions, particularly in Brazil, Peru, Panama, and Trinidad. The virus thrives in areas with high humidity and frequent rainfall, making these regions more susceptible to outbreaks. While the disease is most prevalent in rural areas, urban outbreaks are not uncommon. During 2024, outbreaks have been reported in Brazil, Bolivia, Colombia, Peru, Cuba, the Dominican Republic, and Guyana. The disease symptoms are similar to dengue, chikungunya, or Zika and start 4 to 8 days, with a range between 3 to 12 days after the infective bite. After being bitten by an infected midge, the virus enters the bloodstream and begins to multiply. This triggers an immune response, which results in the symptoms we associate with Oropouche fever. The virus primarily affects the central nervous system. The primary method of transmission is through the bite of infected midges. However, there have been cases where certain Culex quinquefasciatus mosquitoes also spread the virus, making it a concern in densely populated areas with poor vector control. The symptoms of Oropouche fever resemble those of other viral infections, such as dengue, chikungunya, malaria, or Zika. The onset is sudden, usually with fever, ranging from 38 to 40 degrees Celsius or 100.4 to 104 degrees Fahrenheit, intense headache, joint stiffness, pain, chills, and sometimes persistent nausea and vomiting for up to 7 days. Other signs and symptoms include photophobia, dizziness, retroorbital or eye pain, or maculopapular rash that starts on the trunk and goes to the extremities. Less common symptoms can include conjunctival injection, diarrhea, severe abdominal pain, and hemorrhagic symptoms like epistaxis, gingival bleeding, melena, menorrhagia, and petechiae. Up to 60% of cases have a relapse of symptoms after the fever stops. Most cases recover within 7 days, however. In some patients, convalescence or recovery can take weeks. Severe clinical presentation is rare, but it may result in a septic meningitis during the second week of the disease. Abnormal laboratory findings have been documented in some patients with Oropouche virus disease, including lymphopenia and leukopenia, elevated CRP or C-reactive protein, and mildly elevated liver enzymes. Thrombocytopenia also has been reported in a few cases. In areas where Oropouche fever is prevalent, doctors may diagnose the illness based on symptoms and recent exposure to insect bites. Additionally, real-time reverse transcription polymerase chain reaction, or RT-PCR, can be performed to detect viral RNA in serum and cerebrospinal fluid, or CSF, during the first week of infection. The virus is readily cultured during the first few days of the infection and is usually not detected beyond day 5. However, viral RNA can be detected for several more days after the virus is no longer present. Toward the end of the first week of illness, IgM antibodies form, followed by IgG antibodies. In patients with neuroinvasive disease, viral RNA can be detected but is often not present in CSF. Therefore, serologic testing is the preferred method to look for evidence of infection in the CSF. Viral RNA has been detected in saliva and urine of a patient 5 days into the illness. Because the symptoms of Oropouche fever overlap with other illnesses like dengue, malaria, chikungunya, and Zika, doctors must carefully differentiate between these diseases. Laboratory testing helps confirm the diagnosis. Currently, there is no specific antiviral treatment for Oropouche fever. Supportive care, such as rest, hydration, and pain relief, is recommended. Aspirin-containing drugs or other non-steroidal anti-inflammatory drugs must be avoided to reduce the risk of bleeding. People who develop more severe symptoms should be hospitalized for close observation and supportive treatment. Researchers are actively studying the virus to develop potential vaccines and treatments. But as of now, prevention is the best approach. Most patients recover fully within 7 to 10 days without long-term effects. However, severe cases may occur, particularly in individuals with weakened immune systems or pre-existing conditions. In rare cases, the virus can lead to more severe neurological complications such as meningitis or encephalitis, particularly in children, the elderly, and individuals with compromised immune systems. In September 2024, the Pan American Health Organization reported possible cases of OROV being passed from mother to child during pregnancy, associated with adverse pregnancy outcomes, including fetal deaths and congenital abnormalities. These cases are being investigated in Brazil. Work is ongoing to understand the potential risks of OROV infection during pregnancy. Thus, pregnant women should take extra precautions to avoid exposure to insect bites in affected areas. Preventing Oropouche fever mainly involves reducing exposure to insect bites. Some key prevention tips include using insect repellent with DEET, icaridin or oil of lemon eucalyptus, wearing long sleeves and pants, using mosquito nets while sleeping, and ensuring proper vector control in areas prone to outbreaks. Remember not to use repellent containing DEET on children younger than 2 months of age. In conclusion, while Oropouche fever may not be as well known as other tropical diseases, it's a growing public health concern in many regions. By taking simple steps to protect yourself from insect bites and staying informed, you can greatly reduce your risk. This video is brought to you by Dr. Rajdeep Bahadur Khatri. If you found this video helpful, then don't forget to like, share, follow, and subscribe for more content like this. Stay informed and stay safe.